Without further ado, my pleasure to introduce today's speaker, Dr. Josh Felver. Dr. Felver is a visiting scholar in the Bronfenbrenner Center for Translational Research and an extension associate of the ILR School's Yang Tan Institute. He's a licensed psychologist with specialist board certification from the American Board of Professional Psychology. Josh has a PhD in school psychology from the University of Oregon. Before coming to Cornell, he was faculty and director of clinical training in the psychology department at Syracuse University. His programmatic research involves developing, implementing, and exploring biomechanisms of mindfulness-based programs in school and community settings to address health disparities in diverse and at-risk populations. He has written more than 30 peer-reviewed publications and is the co-author of the book Mindfulness in the Classroom and is an associate editor for the journal Mindfulness. So we present Dr. Josh Felver.
Everybody, thanks. I'm delighted to be here. Can everybody hear me okay? This is great. So I'm so glad to be here presenting on my program of research and where this is going on mindfulness-based programming for stress reduction and specifically for youth. Before going further, I'd like to make a few acknowledgements. First of all, acknowledging my teachers who supported me to get to this point, and for my students who were also my teachers. And I'll be presenting some of the work from some of my students today to highlight and elevate some of their work. Also want to acknowledge my community partners, the schools and community agencies I've partnered with, and the youth that I've worked with through the years who have informed a lot of the research that I'm going to be presenting today. I'd also like to double down on the land acknowledgement, the Cayuga Nation and the Haudenosaunee Confederacy that predates my home and this university and the land we stand on. So today I'm going to be presenting on a few big topics. I'm going to talk about stress and health and make the argument that this is something that we should all be considering as applied researchers. And then I'm going to bring it down a little bit to why we should be thinking about mindfulness-based programming as a way of reducing stress to promote health. I'm going to talk a little bit about some of the work I've done supporting youth and children in community and school settings, and also where I see this research going. If there's questions on the way, please interrupt. I'd rather answer questions on the fly. Gives me a break and also better answer questions in the moment. Okay. So to start, just a little bit about me. I'm a local. I grew up outside of Syracuse. I did my undergraduate at U of R, and it was there I got interested in a few big ideas that is going to inform all of my work, including working with youth. I did practicum placements with youth with developmental disabilities and also ran grief and bereavement groups for youth. It was also a time in my life where I started practicing mindfulness, and I had a lot of insights from that of, this is something that's kind of cool. I wonder what it would be like to use this with youth. How would that change youth development? I was not ready for graduate school, so I took a few years to work as a research assistant on a longitudinal bipolar study at Brown, which is a great career path if there's any undergraduates if you're not ready for graduate school, to take a few years, get some real world experience. It was there doing these interviews that I really had the insight around, we should be thinking about schools as a place of promoting health and mental health, because this is the universal intervention that all kids get. Every kid gets school in our country. It's a great place to provide health service promotion. I went to school at U of O to study with Ken Merrill, and his research was on promoting social emotional learning, and with Tom DeShawn, who did a lot of work with parent training. And I wouldn't name them in particular because it was they as my teachers who said, this is our work, but what do you want to study, Josh? And I said, well, there's this thing called mindfulness and clinical psych is using it a lot, but it hasn't really been done in school psychology, and it's not really done in schools very much. And I'm really grateful for them as mentors for saying, Josh, you should make this your own career path. I know nothing about it, but I will support you, which is where really my program research started. My pre-doc and postdoc were in clinical settings. I identify strongly as a scientist practitioner, and so I've done a lot of work across the spectrum of service, and also I integrate my research into the settings that I've been doing clinical work. I've been recently transferred from Syracuse down to Cornell. I love this community in Ithaca, and I love the mission of a land-grant institution to do applied work to better the well-being of our state and that applied nature is really what resonates with me as a scholar as well. So my program research has three big arms. One is developing and implementing mindfulness-based programming and trying to understand it as a second leg. What are the mechanisms, the biomechanisms that could be explaining how these programming are producing some of the health effects we see? And then the third leg is, because this is a relatively new field of scholarship, I'm very interested in how do we improve the rigor of the science, and specifically, how do we integrate implementation science into our work? So the motivation for all this, and I state this because I think this is a shared motivation that many people in this room may have. Why do we do the work we do? And I'm coming at this as a scientist practitioner, and I like to name this intention, and it reminds me of why I do what I do. It's really to promote health. And when I say health, I mean this as a big idea. It's not just about reducing disease, it's about promoting well-being. How do we encourage and promote individuals across the lifespan to fulfill their greatest potential? And that includes physical, mental, and social well-being. It includes academic achievement. And the WHO names this specifically, including it's really important to think about children because that sets the stage for their lifetime development. I say this because it's a way that I think connects with both practitioners and other scholars, and also because it sets the stage for why we should be thinking about stress, because stress is a transdiagnostic risk factor for all sorts of health variables. And there are disparities and disproportionalities that certain groups face because of stress. And it's worth considering that as well. So to build the argument, what is stress? Well, many definitions. Most common is the classic Lazarus definition. Stress is a relationship between a person and their environment. And specifically has to do with when you judge the environment is endangering your well-being and you don't feel like you have the resources to cope. When you're stressed out, animals get this thing called a fight, flight, or freeze response. It's an adaptive response. And you can think about this in your own life if you have to get a little bit of stress for athletics or academic or work deadlines. And it's actually a functional thing that animals have. For example, if we were in the Adirondacks, take a turn or in a corner, and you see this, okay? You would probably, unless you're a bear wrestler, see that this is endangering my well-being, and I don't have the resources to cope. That's an adaptive response, right? But the cool thing about humans is we don't necessarily have to see something that's going to physically danger us. For example, we could be in a classroom, the kid's having a bad day, it's going to kick off the same kind of stress reactivity. This, in some ways, endangering me, and I don't have the resources to cope. Again, it's not a good or a bad thing. And in fact, it's adaptive in an acute context. The problem is when it happens over and over and over, it grinds you out. And that's called chronic stress. It's kind of like cars has red lines. It's for when you accelerate on the highway, right? Or you need to pass someone. But if you're always revving it, you're going to grind out your car, wear out the engine. And similarly for humans, stress predicts all kinds of health outcomes. It predicts mental health very strongly. Anxiety, depression, internalizing symptoms, unhealthy coping behaviors, substance use, things that we do that are in maladaptive coping strategy for stress, physical health, cardiovascular disease. It affects interpersonal health, job performance. It also affects and predicts out educational achievement and whether you leave an occupation, something called burnout. And I'll talk about toward the end, decision-making ability. It affects our cognitive functioning as well. There's a lot of sources for stress. I might just name a few. Pandemic comes to mind. Okay, so these are some stresses that everyone experiences, right? No one's unscathed from the pandemic. There are also specific stresses related to trauma. Something about living in poverty, community violence, adverse child events. These are stressors that people experience as well. And there are occupational stresses. 3 occupations that come up a lot in the literature are first responders, police, and teachers. Teachers have an occupational risk for stress. And you may have heard about the teacher shortage. Well, that's largely attributed to burnout and stress, particularly for early career teachers, particularly for teachers who serve students with disabilities, special education teachers, and particularly for teachers who are working in communities that are under-resourced, meaning they serve primarily students of color and they serve communities with high rates of poverty. I'll come back to that toward the end. A few other sources just to name: parenting is stressful, particularly if you have kids with increased caregiving demands. Minority stress: if you're a minoritized group, you face different stressors than other groups, including racial discrimination, and sexual and gender minorities experience unique stressors by virtue of being in a minority group, which puts them at risk for all other kinds of health outcomes. Also want to name adolescence, okay, most stressful time of the human lifespan. And this is all to say that the accumulation, the intersection of these stresses is a major public health concern. We can see this if you just Google stress and blank, right? So here's a few headlines I just grabbed for today. Parents are stressed. Okay, that's the headline for a paper, apparently. It gets your attention, right? We know this, right? We've heard a lot about healthcare providers, the burnout and stress that they experience, particularly during the pandemic. We can think about the mental health crisis that youth were experiencing before the pandemic and is only exacerbated. This is ongoing. American Academy of Pediatrics, American Academy of Psychiatry are naming is a crisis right now, and it's getting worse. Children's mental health in crisis, okay? This is from just the other day, and it names schools as being an important venue because the largest provider of mental health services comes from schools. This is also important to think about, just like caregivers and hospital settings, teachers. Teachers are, this is the headline for a paper, it came out, or one of the science review websites. Teachers are not okay because the context of a teacher in the classroom sets the stage for children's health and their learning. So there's my doomsday slide, right? So what are we gonna do about it? Well, bad news. Stress comes from all sorts of places. It's really difficult to mitigate because it's from different sources and it looks different for different people. And it's pervasive, it's a large scale. Fortunately though, we can target the individual responses to stress. We can teach individual how to respond to stressors regardless of the source because it shares similar factors, which gets at this idea of stress buffering effects. And this is where mindfulness comes in, because among the stress buffering interventions we have out there, mindfulness-based programming has a lot of evidence for it, specifically because it mitigates the way that stress works. So what is mindfulness? Well, you ask different people, you get different definitions. The most common one is this from John Kabat-Zinn, developer of mindfulness-based stress reduction, the most commonly used intervention in the Western context. It's the awareness that arises when you pay attention on purpose, in the present moment, non-judgmentally. And this is the definition you'll see most commonly. Say it differently with a little more operational specificity as a psychologist. Self-regulated attention to immediate experience and a quality that is characterized by curiosity and openness. So if you're going to think about what is mindfulness, I would think about it in those two levels. Self-regulated attention to right now, and the quality of that attention is open and accepting, letting things be as they are. A few things real quick. Mindfulness is not Buddhism. I want to acknowledge that a lot of the practices do come from Eastern religions, but the practices themselves are not necessarily religious. I like to use the analogy of fasting is a practice used by many religions, but fasting is not religious itself. Similarly, these practices that we call mindfulness-based programming are just that. We can operationally define them. We can teach them with specificity in our cultural context. Meditation is not very specific. I don't like to use that word. Attention is related to it. How do we pay attention to right now with that openness? Mindfulness is not an app or a quick fix. When I teach MBSR, I like to make a quip. If you like a short-term fix for your stress, better off having a glass of wine, okay? This is not a short-term fix. This is not a PRN medication to fix stress right now. This is changing your fundamental relationship with your environment and so that you have less stress in your day-to-day life. And lastly, mindfulness is not a fad. It's getting more and more popular. Here's an example. If you go on NIH Reporter and use keyword mindfulness, this is going from 2018 to today. These are the number of funded projects that have mindfulness in the title. This graph here is 2022. This blue line is R01 funded projects. And The low end of that is $1 million. This is hundreds of millions of dollars that just the NIH is investing in mindfulness research to promote health. And I'll add one other thing because it just came in my inbox today. I've been reviewing grants for the NIH for a few years, specifically for mindfulness in community settings. I was recruited for this. I got an email today, special emphasis panel for mental health promotion in schools using mindfulness. This is a very targeted and focused and hot research topic. I'm a visual person. This is the way I like to present it a different way, because you're going to get different answers. What is mindfulness if you ask different crowds? So here's an example. In this context, I'm not going to walk you through mindfulness practices, although I like to do that. But we'll just do a real quick just thought activity, okay? So pretend this bowl is what your experience is like right now. And if you break this down, right now you have thoughts. What a great presentation, this is great. What's for lunch, whatever those may be. Smells, tastes, other sensations, feelings, whatever's going on in your body. All these things are happening, memories. And if you think about it, all these things that are happening all the time, if you really pay attention to right now, this is the content of your experience. These are the individual elements that comprise this thing we call being. Mindfulness is not a content. Mindfulness is the context. Mindfulness is the awareness. Mindfulness is the bowl. It's the awareness of these things happening. It's not a discrete psychological phenomena. It's the thing that's noticing those other things happening. So I like to think about questions. I think questions are the way science moves forward. Question I asked right off the bat when I started this program of research, does mindfulness-based programming work? Well, this curriculum has been around for a long time. I acknowledge that. And I'll distill what we know about the science today. Yes, and it works in a few contexts. It has heterogeneous health effects. It improves well-being, reduces psychological symptoms. There's lots of mindfulness-based research. This is why it's getting a lot of funding and attention. But the most consistent finding in both healthy and in clinical populations is reducing stress. Okay, that's the most consistent finding. That's the most evidence for that. I want to name, again, we're thinking about this transdiagnostically. I want to acknowledge that it does not target the systemic roots of stress. That is a very, very important topic. And it's one that we cannot ignore. This is a part of the solution. The work everyone's doing to target the systemic roots is critical. This is thinking about it transdiagnostically. How can we teach people to respond to the environment so they have less stress regardless of the context? Okay, so why does this make sense? Well, here's that definition again. Judging the environment to endanger my well-being, and I don't have the resources to cope. The mindfulness stress buffering hypothesis connects these because ultimately what we're really doing when we teach mindfulness is teaching awareness and objective awareness with acceptance. Can we alter stress appraisals through being objective about our experience? Because truthfully, we have very few bears attacking us day to day, even though in our minds we appraise these as stress. How do we teach people to appraise things objectively as they are, and the objective appraisal can alter stress? And we're also teaching a coping resource. When you practice mindfulness over time, in some ways you're practicing relaxation, which gives you more resources to cope, essentially. These quotes really sum it up nicely. In stressful situations, I could take a step back and pause before I respond. When I'm encountered, for example, with giving a talk to high-profile colleagues at an Ivy League institution, I can take a step back, or I attempt to, and say, how do I want to respond here and not get carried away by thoughts and be really in the moment? How do I want to respond right now? I'm a visual person. Here's another way of thinking about it. Stress strongly predicts health, not just reducing disease, but promoting health, and has direct health effects, onset of disease, hypertension, et cetera, and indirect effects, okay? Ineffective coping strategies, cognitive functioning. What we think mindfulness is doing is that it's altering stress and having indirect effects on health. And it's doing that through two physiological pathways, which I'll just touch upon. A top-down regulatory pathway. So this would be like the reappraisal aspect, objective awareness. the blue area, the frontal cortex, and a bottom-up pathway where you alter the reactive patterns that we have in our life and build up the resources to respond and not react, such as by altering like the HPA axis at a very gross level. This is the conceptual model that all my work is based upon, and it explains a lot of the heterogeneous health effects of mindfulness. So here it is again, stress affects health. If we can buffer that, we could have health effects. So the question then is, well, does it work for youth? And that's where my research started. When I started this topic with the support of my advisors, this was not being done very much in schools. It was not integrated to the field of school psychology. So to start off, I thought about, well, how can we make this work? And the way we conceptualized it is thinking about mindfulness-based programming for youth using a multi-tiered system of support, which is a public health model that seeks to match the level of need, level of intervention to the level of need. So in this model, which is commonly adopted, it's in schools, it's in other public health settings, a universal intervention would be one that's more prevention focused. So this would be like the core reading curriculum in a school. This would be putting fluoride in the drinking water to prevent cavities. Everybody gets this, it's prevention focused. A targeted level is indicated. If there's a risk factor for small groups, we can provide very targeted prevention interventions and also very targeted interventions. And then at the intensive level, this would be the people with the highest need. This is individualized, or very intervention focused. This is very tailored for a specific problem, usually at the individual level. And this is the model that's guided a lot of my work, thinking about it from a public health standpoint. I'm going to go through a few studies we've done. I'll touch upon them just to give you a sample of how we can think about mindfulness and for different sources and different contexts. So at the universal level, we did some studies looking at teaching dyads of parent children adopting mindfulness-based stress reduction for parent and child. What we found was that children had improved attention regulation. And when we put parents in an fMRI scanner, a lot of the areas of the brain related to emotional processes and motion regulation were altered. And actually that was related to the children's behavior too. We looked at Kripalu yoga in the schools. This is an existing curricula, replicating this curricula in public schools during gym class. Gym class was great because you have a very nice baked into the cake control group to compare against. The age of weightless controls is over. We have to think about active comparison conditions. So general PE versus yoga. We found that we had mood effects for adolescents. We found some really cool findings with social emotional strengths. And the interesting thing here was the context, because it wasn't that the kids were having increased social emotional strengths. They maintained their social emotional strengths while the control group dipped toward the end of the year, which we attributed to the measurement time point being during state testing. Learning to breathe is another curricula. It's very popular. We've replicated this, bringing it into public schools during health and wellness class. And I want to show a few recent studies. Mindfulness-based stress reductions for undergraduates. We found changes to anxiety, which I'll talk about right now. I want to bring this up because it's actually a really cool way of integrating this into work that we do with undergraduates. In this context, we looked at mindfulness-based stress reduction as part of a course learning about mindfulness and stress. So you have a dyadic lecture-based class, and then the laboratory is learning MBSR. And then we compared it to the quasi-experimental, same instructor teaching a similar course. And what we found was that the reporting changes, the dark line is cognitive self-regulation. So students who were in the mindfulness group have increased cognitive self-regulation, while students that are not have decreased throughout the term, or about the same actually. And changes to their state anxiety, which is a pretty good marker of stress that we used. The cool thing from this study, though, was that the changes to their self-regulation actually longitudinally mediated changes to their state anxiety. At the target level, we've done a bunch of studies. So these are indicator groups that have shared characteristics. We looked at, this is probably my study I'm most proud of. We did some work with a residential child psychiatric center, And in this context, children are removed from their homes and they're at a residential facility for months, not weeks, months, receiving psychiatric care. Very high rates of seclusion and restraints. So this would be a kid who has a behavior problem and they get held or put into a room where they can't get out. Very traumatizing for the children, for the staff, and very damaging. It's a risk for them getting hurt. In this study, what we did was throughout the week, about half the week, different days, they started their morning off with mindfulness and yoga. And on the other days of the week, they didn't. And we just looked at, well, what's going on with their seclusions and restraints? We found significant reductions during the days they practiced in the morning relative to the days they didn't. And that's a really, really important finding because it shows that a small investment in prevention can mitigate them having emotional bursts, blowouts, and behavioral that was necessitating them getting restrained. We've replicated MBSR for undergraduates and graduates. This is just a nice replication trial. I'll talk about soles of the feet in a moment. This is a brief mindfulness intervention. We've adopted it recently at this level for students with test anxiety, because people with anxiety and anxiety-related disabilities, if they get anxious when they take tests, they do not perform as well. We've recently done this. I was hoping to have the data analyzed in time for today. I did not, but we have cortisol data we took during when they actually took their final exams. I worked with the Syracuse University undergraduate advising office. And I asked them, where are students most stressed out? They said calculus 1. So that's where that data came from. This study, I'm going to zoom in a little bit. 5 minutes brief practice. How does doing a very, very basic practice every day affect the school for the whole year? And so for this study, what we did was we were working with a middle school in Syracuse, predominantly in a high poverty community, disproportionately low academic outcomes, majority Black students. And what we did was we randomly assigned by classroom for the whole year that they started off their English class with 5 minutes of mindfulness. So in one condition, they practiced mindfulness for 5 minutes for the whole year. In another condition, they did 5 minutes like an academic warm-up activity. What we did for a measurement for this, it was looked at curriculum-based measures of reading. This is not asking the teachers, hey, how do you think your students are doing? This is actually measuring their reading performance. This is what it looks like. You have 2 minutes to read this passage. And when you get to these laser work, these bold areas, select the word that fills in the blank. So this is a measure of reading fluency, but it's also a measure of reading comprehension. It's very widely used. And this is what we found. The dark line is students doing the mindfulness. The dashed one is the control. Thankfully, they're reporting, I feel more mindful throughout. Okay, that's not terribly interesting, but it's a manipulation check. The thing that was very interesting, though, is their reading performance. This is their CBM scores from January to June. We saw significant changes depending on what group they're in. We think that these changes are happening. We have a few hypotheses for why they're happening. One is that they're less stressed out when they're taking the test. Another one being that because this is a measure of paying attention, perhaps they're paying attention better when they take this test. So we're hoping to do more follow-up studies to examine this. The targeted level, most of my work has been with an intervention called soles of the feet. This is a targeted intervention for disruptive behavior. I'll talk about it in a second, but we've done a few studies with this in a general education context, looking at off-task behavior. In a special education context, this is one of the first studies to be done with kids with disabilities using mindfulness interventions. We also did with some special populations, youth diagnosed with ADHD. We looked at math performance. And a recent study I'm going to talk about in just a second is youth with autism spectrum disorder or autistic youth, looking at their classroom performance. Soles of the feet is an interesting intervention. It's a little bit different than other ones. It's a very literal title. We're teaching people to notice when you get upset and move your attention to your feet. I've worked with the developer for this for years, and I started this in graduate school. And the history behind soles of the feet is that Nurb Singh developed this for adults in group homes who had intellectual and psychiatric disabilities. And we needed a basic mindfulness intervention so they would have less aggressive behavior in the group home setting. I reached out to NERB, looking for curricula to be easily adapted for school settings. And we spent years iteratively refining this with single case research design studies to develop this for youth in school settings. And I want to do a plug. We just had a paper come out on behavior mod, a meta-analysis from my lab, NERB's lab, and a few other labs across the world. And I can say that this is technically an evidence-based practice for disruptive behavior. When we did the moderation analyses, it's robust against age of the participants, age 7 to 68, I think was the oldest. And it's robust against disability status, with or without intellectual disabilities. For these studies, when we talk about off-task behavior, I want to show this as an interesting measurement procedure. We use direct observation. So what we're doing is going into a classroom and people are observing a single student, and every 15 seconds they're coding, are they on task, or are they off task? On task means they're doing what they're supposed to be doing in the classroom, visually oriented toward the teacher, completing their assignments. And off task is they're not. This could be getting out of their chair, verbally aggressive, physically aggressive. This is them not learning. And this is really important to note. If you're off task, you're not doing the classroom expectation, and you're not able to learn. And we do observations for about 20 minutes, coding every 15 seconds. It's called direct observation. In this study, we looked at children with autism, or adolescents, or autistic adolescents. They were recruited because they had very high rates of off-task behavior. We wanted to see, would it be applicable in this setting? So here's a study that just came out in mindfulness. I'm going to break this down because this is actually a really, really important data. These are the students' actual behavior in the classroom. Every one of these dots is a 20-minute observation of them in the classroom. So if we look at Gil here, one other thing to orient you to, this line is when they got the intervention. So this is them before they learn the soles of the feet, and this is them after. Every dot is a 20-minute observation. And if we look at Gil here, during this period before he learned soles of the feet, about 40% of the time he was off task. So I'm going to pause there. 40% of the time when he's in the classroom, he's not learning and he's disrupting his peers. After learning soles of the feet, reduction to around 20%, which isn't great, but if you think about it, that's twice the amount or half the reduction of time that they can actually learn. This is significant as an experimental design, but it's also significant clinically. These are students who are learning more and not disrupting their peers. So, as you can tell, a lot of my research is done in schools, and I want to talk next about what does this look like for the future for doing mindfulness-based programming in schools, because this is a place where we can provide a lot of health promotion. I've gotten interested in schools from different angles, and I want to name a few things that are informing a lot of our current work in the field, namely implementation and implementation science and poor reporting. So when we've done reviews of this, the most common limitation in the field is that programming, there's a bunch of limitations, but the most common one is that it's services are being provided by outside instructors. So you're hiring someone from the community to come in, teach mindfulness, not sustainable, and it loses some contextual validity. And also there's ecological factors to consider. So here's a graph just looking at implementation, which I'll unpack a little bit. But typically when we think about what's traditionally been done, provide a programming, the participants measure an outcome. And this is an antiquated model that does not capture the full context. I'm going to talk a little bit about thinking about who's delivering the programming and thinking about the context of schools. I'm going to illustrate this with a few studies we've done recently. Because again, there's that doomsday slide. If teachers are not well themselves, they're not going to be able to educate their students, and it affects the students indirectly in the climate. So the question is not about, does mindfulness programming work in schools? The better question is, does it work for school staff to indirectly support youth in context? I think this is the question that we're going to see in the field moving forward. This is kind of where we're at right now in the literature. So here's one study we did recently. A small pilot study, but it's worth noting. I was approached by an administrator in the Syracuse City schools who was really concerned about the health of their principals. So I said, okay, well, let me do a little bit of literature review. Turns out the high school, met some principals recently. They are very stressed out. Okay? It's an untenable, really unhealthy job. There's literature behind this. Said, yes, this is a good idea. What can you give us? What are the confines of the training? They agreed to 2 one-hour trainings, but those got whittled down to 45-minute trainings. Great, we'll take it. So we decided to deliver 2 trainings, just teaching a 5-minute basic mindfulness breathing practice. And we asked them, look, just for the next few months, just try to practice 5 minutes a day before you go to school, because there's evidence that this can actually help your health. Half of the 11, in a very small study, completed this, and I'll share that data in a second. I do want to note that half did not. And this is an irony that's kind of funny, but it's not, because they're reporting they are too busy and too stressed out to attend the stress reduction workshop. We measure with a screening for psychiatric symptoms called the brief symptoms inventory. This is a screener that's used in outpatient medical settings. So if you go see your general practitioner, your GP says, hey, you look a little, wondering if your mental health's okay, here's a screener. We use this as our measurement. Here are the 11 principals. This is most of the elementary school principals in the Syracuse City schools. Along the y-axis here, we have their T-scores. These 5 principals scored high enough that if they completed that form in their GP's office, they would have been sent for a psychiatric evaluation. 2 of them endorsed suicide. The ones that completed it, the orange bar, is how they reported it 2 months later. And it was significant enough that they would not have been referred for a psychiatric referral. So, small study, I'm not going to tout the statistical significance, but I do want to mention the clinical significance. This is meaningful, and it's also alarming. The people with the highest stress are the ones that didn't come to the follow-up intervention. It would be a problem for me not to give a talk here and not talk about an ecological model. So I want to talk briefly about the context. How do we think about the broader ecological context of mindfulness programming? I want to talk a little bit about decision-making, because we've talked about health, but stress also affects our decision-making. And this is a place where it can affect our personal biases. So I'm going to talk a little bit about a recent study we just did with teacher bias. First, before I say anything else, I want to acknowledge I'm coming at this work as a white, straight, cis male. I don't have the lived experience of this work. I don't have an embodied understanding of this. I want to acknowledge this with humility. I also want to say that I'm coming at this completely from an angle of, I think there's an area here that we really need to focus for health promotion. Because here's the context for this study, why we should care about biases of teachers. The context is that there is a disproportionate disciplinary practices experienced by Black youth, okay, way higher than white youth. And this is a major problem, twice the likely to be suspended and expelled. This is a huge problem because being suspended and expelled very strongly predicts achievement, dropout, and incarceration. And it's also important to think about this in terms of bias because we have evidence that one of the reasons, and the largest reason, why Black students are getting suspended and expelled more has to do with these ambiguous situations where the teacher has some discretion around, do I write them up for a behavioral infraction or do I let it slide? And this is a place where bias comes into play. We became interested in this because there's evidence that mindfulness does reduce bias, not just because reducing stress, because when you're less stressed, you're going to make better decisions that are in line with your values, but also because we're teaching awareness. If you can notice your bias patterns of thought, you're less likely to let them influence your behavior. Mindfulness also promotes compassion, certain mindfulness practices in particular. We thought this was something worth looking at. So the question is, does it moderate biased disciplinary practices? I want to elevate the work of Tori Ash, who's one of my students. This is Tori's work coming out of our lab. And it's really important work because this is laying the foundation for how do we leverage mindfulness-based programming to do something that's very, very important in addressing a disparity. Here's the context. About 200 students. The study was done during COVID, okay? which is important because it's really hard to do studies during COVID. And we gave them a cover story. Read this disciplinary infraction, and we're interested in what you're going to do with it. So this is a common form that they would get in a school setting. Basically describes what happened. So here's a student that's being insubordinate. Teacher's asking them to pick their head up. Students ignoring them, continues to ignore the teacher. And the teachers are asked, reading this infraction, what are you going to do? Here's the manipulation though. For randomly assigned the teachers, half of them received this report where the students signaled race was Black, and half of them received it where the students signaled race was white. And we did manipulation checks and this worked. Here's what we found. After reading that, we asked them, given that infraction, what are you going to do? How would you rate this? Would you send them to the office? Should they be punished? Should they get an office disciplinary referral? This is the mechanism that suspensions and detentions happen. We found, as we expected, that Black youth were rated more harshly than white students. This is replicating previous research. And we found that teachers' mindfulness moderated these ratings. The teachers who reported lower levels of mindfulness were more likely to rate students, Black students, needing harsher disciplinary practices. This study is coming out, I don't think it's in print yet, but it's going to be in the journal School Psych. Yeah.
Just wanted to affect their harshness for white students.
That's a great question. That was interesting. So it's better to show you the graph, which I don't have here. But yeah, that was a part of it that we're actually exploring more. The major part was that less mindfulness, harsher ratings for Black. Higher mindfulness had, be able to show you the graph. There was an interaction. So yeah. Yeah.
Were you able to get any evidence of that consistency of ratings? Like if you were to rate multiple students with similar infractions, would you expect different degrees of variability in kind of a rating or a decision? And would that be moderated by mindfulness?
So meaning the question is about consistency, meaning like if you're rating students over and over again?
For different students.
Yeah. Kind of in the study. I showed you two names, Deshaun and Jake. We actually had a bank of like 10 names that we used from previous social psych studies. And it was consistent there. So that's kind of getting at it. I don't have data for multiple students if they were just over and over. The infractions got more and more severe, I should know. So we monitor, it's an escalating pattern. So we're trying to get the teachers primed for this one student. It's called the troublemaker paradigm. They're continuing to do infractions and we monitored. So what are you going to do about this? And that's a real world context that the teachers are asked to make those decisions. So the big thing here is that we have some evidence that mindfulness training could promote equity. But we need a lot more research, which is what I want to talk about now. What are the follow-up studies? Where are we going with this? I'm going to talk about 4 studies I'm hoping to embark on as I drop the mic. The first one has to do supporting youth in context, okay? This is a follow-up research that I'm putting together a grant for. How do we support teachers? And this is the idea behind it. When you go on an airplane, the reason they tell you to put your mask on first before the youth is that you're not going to be able to help the youth if you're unconscious, right? And this is a logic that we use when we do parent training in a clinical context. And it's the same logic that we have to think about with teachers. If teachers aren't healthy, they're not going to be able to do their job as well. Furthermore, there's a certain situations that we really need to pay close attention to. I would on target looking at special education teachers because they have much higher rates of job attrition, much higher rates of stress, and in particular, special education teachers who work with students of color in under-resourced communities have way higher rates of burnout and attrition. This has disastrous effects for the education of students with disabilities. So I really want to help work to develop a program thinking about implementation science. What could be an acceptable and feasible intervention? I want to leverage technology to make it an asynchronous training to teach a very basic practice because If we can get, there's evidence to support very basic doses of mindfulness could have big effects. Another area of research I'm interested in is continuing to adopt unique contexts for targeted interventions. I'm going to elevate the work of one of my other students, an excellent young scholar, Emily Helmanen, who is on the job market, you know. Emily's work is really looking at mindfulness and self-compassion to buffer the effects for sexual and gender minorities. And I think there's a lot of legs here for applying this in school contexts. I would like to develop programming to look at how we can leverage things such as gay straight alliance organizations to develop compassion and mindfulness training under the unfortunate assumption that there are unique stressors faced by LGBTQ students that are not faced by other peers that contribute to the very, very high rates of suicide and very high rates of substance abuse in this population. I'm also interested in scaling up evidence-based practices. I'm biased that my baby soles of the feet, but I can say it's an evidence-based practice that's ready for scale. Lastly, I'm interested in continuing to think about how to improve the state of science. Mindfulness-based programming is in its infancy, and there's a lot of lessons from implementation science that we can draw from to improve programming in the future. It's not out yet, but the December issue of Mindfulness is a special issue on this very topic, mindfulness programming in schools. I think it's worth paying attention to. There's a few contributions I want to note. I've talked about context. There are a lot more things to consider. So if you listen up, if you're interested in school-based research, this is where it's going. But if you're interested in community-based research, these are things we need to consider. There are a lot of factors. To do implementation science well, regardless of school-based mindfulness, you need to be thinking about the context. You need to be thinking about what we know from implementation science. What are the core program components? I've done some research. That's my contribution to the special issue, breaking down what are the constituent elements of interventions. You don't know if you can't operationally define what you're doing. You can't do the component analyses. You don't really know what the active ingredients are. Thinking about the implementation support system. Interventions are not delivered in a vacuum. There are supporting elements that support this. If you don't name them and measure them, we don't know if an intervention can be replicated. The question is not if an intervention is effective, it's effective for whom and under what conditions. Thinking about the participants, both who's delivering it and who's receiving it. These individual difference factors are important to consider. The context, not just the school, but the broader socio-cultural context. And then all of these other implementation factors that we must start considering. Quality of implementation. Was the intervention done with integrity as it designed? Was it done with competence by the instructors? Defining what competence is for the certain situation. Was it adapted? And if so, how was it adapted? These are things that are not reported, certainly in the school-based mindfulness literature, but they're rarely reported in clinical trials and community settings. You really need to be paying attention to this. Thinking about dosage, not just what you're delivering, but how much is the uptake? Those are two different things. And the goodness of fit. Are people being responsive to the interventions? Is it feasible and acceptable? This makes for much more complex clinical trials, but if you don't measure this and consider these factors, you're missing the big idea that not all interventions are going to work in different contexts. We really need to be considering this. Many people here are researchers, and I know some people are also clinicians and providers. If you're interested in mindfulness programming, so I'll make a few notes. This is a great time to practice. So if you're interested in practicing, start today. Arguably, there is no other time to practice. So start a practice and you'll get insights from your own practice about how you can leverage this for your work. If you're interested in doing research on this, keep in mind that a lot of well-intentioned instructors may have expertise in teaching mindfulness, but no expertise in your context. So they may not know what the specific contextual factors are to consider, and vice versa. You really need to have expertise in both. And lastly, this is kind of like an anti-plug. If you're interested in mindfulness in your context, I urge you to think about what are best practices. Unfortunately, I love mindfulness research. It's my career, right? in your context, there are other evidence-based practices, and in some settings, mindfulness might be the right tool. In other settings, it may not be. So thinking about what's the best intervention for your context is really important. Stress is a public health concern. We need to be thinking about it and how we can reduce disproportional stress and the health effects. And we know that mindfulness reduces stress. You can think about it, different multi-tiers of support. And we can think about how implementation science can be leveraging to inform the future of this research. This is a quote you see a lot that's misattributed to different people. Be the change you want to see in the world. I would make this call. You're already the change you want to see in the world. It's worth paying attention to how you relate to yourself, to others in your context to promote health. Thanks for your time. Thanks for your work. And I want to name my colleagues, collaborators, and some of the funders who supported the work that I presented today. Thanks.
Yeah, I would just, oh, yes. I'm grateful for those slides there at the very end, understanding the context in which you're working. And it's interesting, I've had some involvement in implementing these programs, both in prisons and in psychiatric institutes. And like schools, they all represent kind of sometimes crazy making, kind of bureaucratic, clinical obstacles in getting it done. And even every school is not going to be the same. Some of you may be warmly greeted in others. So it just, I'm grateful that you had that and would just underscore it in spades for these high-risk kinds of environments in which we're implementing these things.
Thank you for saying that. Schools are a uniquely challenging place to do research.
Well, try to.
And you know what? They're compared a lot, right? Because there's no student signs up like, I want to take a mindfulness class. They're a captive audience, so that changes the context. People aren't, just like with child therapy, children don't self-refer. And schools is a captive audience, which is great for universal interventions, but there's unique context. It is a very difficult place to do research. So thank you for saying that.
There was a recent study in the UK, this myriad study that came out with no effect or even, kind of like bad effects.
Yes.
Is there
Yep.
part of that implementation model that you would point to in terms of that study?
Yes, actually, last night I took out that slide because it's a downer. Well, thanks for bringing it up. The largest trial of mindfulness, school-based mindfulness interventions was just completed in the UK, the Myriad study. 853 schools and 18,000 plus students looking at mental health outcomes in youth. Null results. Why? We as a field met for a conference like a few weeks after that study came out, and we sat down with some leaders and we thought about this. We think the major reason that we're not seeing the results, two big things that we kind of came to. One was not thinking about implementation science, not thinking carefully and critically about what are the variables that could be influencing this. And two is not thinking about things as health promotion. So that study looked at mental health outcomes. Can we get reductions? But it gets at ceiling and floor effects, depending on how you think about it. That in a normal population, even with high rates of mental health, you're not going to see the same kind of rates for reductions. There's not as much wiggle room. We think that was it. And then lastly, there actually was a third, even larger one. We need to think about teachers. Teachers need to be trained. And they did a pretty good job of training them, but we need to think about what is the competence of the teachers, what are their own practices, and what is the measuring the climate and the contextual variables. So I'm glad you brought that up.
But I appreciate that they reported the negative result, because I think there's so much hype about, a lot of us who teach mindfulness practice it and we love it. And we,
Yep.
we want to kind of proselytize. So I think it's good that we also see some studies that have not the effects that we anticipate.
Absolutely. And that's a lot of the impetus for looking at working with teachers. That's one of the big findings from that.
Online questions. So we're going to
Oh, yeah.
bring it back here to Liam and he'll read the question.
Okay, so related to context, what about youth who have experienced trauma and may have PTSD? They said, I have read that this can make meditation and mindfulness exercises harmful unless they are taught differently. Also, that youth with ADHD have more need to move and may not do well when asked to sit still to meditate. Have you found any research on this?
Yes, wonderful question. So the question around iatrogenic effects and contraindications. Mindfulness-based programming, when you teach to adults, there are specific settings where you want to be very, I'm looking at you like you asked the question. Sorry, all my it's contraindicated for people who have recently experienced trauma, panic symptoms, and also recently in substance use abstinence. It doesn't mean that you can't do it. It just means that if we're training self-awareness, and a lot of, for example, trauma responses is about avoiding and kind of pushing down some of these traumatic events in your mind. If we're teaching awareness out of support for what happens when you start noticing those traumatic experiences, you can have iatrogenic effects. So in a clinical context, it's done very carefully. Can it be used for trauma? Can it be used for the settings? Yes, but not out of context of additional supports. So you would never want to teach it, for example, someone who's recently experienced a trauma, you'd really want to make sure that they have existing supports and mental health supports in addition to. Youth with ADHD, I think I've done some research on that too. The short answer is that you can't just take an adult intervention and make it kid-friendly. Kids are not little adults. There has to be a lot of contextual adaptations for that developmental period. And youth with ADHD are not terribly different than other kids who are typically developing. They can't sit still for 45 minutes on a cushion. So we have to adapt that and think about it differently. I think movement-based interventions are really the way to go. So we don't ask kids to sit on a cushion still for 20, 30 minutes. We do a lot of movement, somatic basic exercises. And I think that's why Souls of the Feet is very effective too. Thinking about other parts of our body as a way of fostering awareness.
Thanks for that interesting talk. So I was struck by the dropout rate that you showed. I think you said it was among the people who were very stressed.
Yeah.
Which, suggests that these people view this as another thing that they have to do. And I was thinking, which to me suggested it's not only about implementation, right? It's you can have perfect implementation or very good implementation, but if folks are viewing the intervention as just another thing that they have to do,
Yes.
That's a separate issue. I was thinking of implementation in a slightly different context, same word, but different usage. So the implementation intentions work where, the nature of the intervention comes online when you experience, in this case, the stressor, right? So it's an if then kind of thing.
Mm-hmm.
I'm wondering if your work can speak to that, because what I've heard was, these people go through this intervention, 6 weeks, 5 weeks, and then they're kind of expected to, engage in that intervention when they're feeling stressed. But I'm wondering if the nature of the intervention itself can be tailored so that, it comes online, so to speak. So you're breathing when you encounter, a stressful sort of thought or I don't know if you can speak to that.
Yeah, absolutely. Those are perfect points. So the first part you were talking about, that's the difference between like feasibility and fidelity. So thinking about not just delivering intervention as intended, but thinking about the contextual factors, was it feasible? So thinking very carefully in that context, something about the program delivery was not feasible. And we got some qualitative data to look at that. And it really is about having the protected structured time. So I think a lot of our school-based work, for example, building in the structure to support this. It's one thing to say, 5 minutes of meditation is good for you, you should go do it. It's another thing to say, principal gets on the announcer and says, it is the mindful minute. Everybody put your books down. We're going to sit in quiet for a few minutes to collect ourselves. Setting up the structure and then makes it more feasible. We're also carefully asking that question. Your second comment was absolutely correct. I would liken it to something that I say to as a clinician, kids in my office. I'm not really that interested in what you do when you're here with me and how you feel right now. I do care about that, but I'm interested in what you do when you leave my office. And I think there's a lot of things we know from implementation and behavioral science about being very specific, okay? And that's the reason why at an individual level, one of the things that Souls of Feet's really good at, we brought in a lot of behavioral technology saying, all right, you can do this intervention in my office. Like, great. When are you going to do it tomorrow? Name the time, the place. We have visual prompts and teacher prompts, setting up the context that the teacher can come by and give, this is a good time to practice. They're getting upset. Having little visual reminders in the room, remember to breathe, things like that. But also being very specific. When you're, and this is not special to mindfulness, but it's being very specific about being very good clinically around naming the deployment of the skills for when it's needed.
Thank you very much for your remarks. Maybe my question is actually an extension of the one that you just responded to, but I don't know yet. I'm curious about your data where I think it was with the youth from the residential psychiatric facility and how you looked at days on which they practiced mindfulness versus days they did not.
Yes.
And behavioral enactments were different on those days.
We measured the incidence of seclusion or stress. So so it's like kind of secondary, responding to
what they were doing.
Yeah.
So it maybe listed at different things from staff who were working with them.
Yes.
I'm curious if one inference to be drawn there was that mindfulness was helpful on days they practiced it, on days they did not. I'm curious about what that says about mindfulness as a practice. Is it that its effects or potential benefits are not surviving sleep cycles? That even the next day, whatever happened yesterday isn't carrying over?
Yeah.
And therefore it resets as opposed to some other kinds of interventions that sort of equip people with something that they kind of, it's more enduring. So is this something that we should get into to the question of the null findings? Is there an insight there about how often this should happen in people's lives to sort of have continuous effects?
Oh, I love that comment. Thank you for that. So the enduring effects of practice. We have a few hypotheses for these. So yes, we should absolutely think about this. For us on the trial and the interventionists and the researchers, when you start developing any new practice, I think that's building up behavioral fluency is one way to think about that. It takes a little while to get those behaviors to become naturally part of ourselves. So like we learn any new skill, do it enough times, you get more fluent at it. So I think that's part of the answer to it. Just building up a new skill. And that could be something that's intentionally deployed, or it could be something that you're just getting more fit, if you will. You're just practicing it, kind of that bottom-up pathway. As a practitioner, I would answer it from my own experience that I notice the days where I take the time to sit in the morning are qualitatively different than the days I don't. And I'm not sure why that is. I think that it sets the stage and maybe it gets reset with your sleep cycle, or maybe there's just a dosage effect. But I also notice that if I'm very good about my practice, it's a judgment, right? If I'm more consistent, it changes, those effects bleed over for multiple days. And that's something that's not looked at very carefully, but I think it's definitely ripe for research. Yeah.
Two separate little questions. Something that you just said reminded me, in this residential care facility, were you also looking at, was staff practicing mindfulness alongside, and did that have any effect on whether they were writing up or restraining, extra restraining sector? That's one. And the second one is, are you collecting qualitative data from the youth in these studies alongside this quantitative, like reading comprehension data? And if yes, what kinds?
Great questions. For the residential childcare setting, that was a study that was done from an outside provider. So the staff were not directly involved. I was hoping that they wouldn't even know if the kids practiced that morning, but some of the staff did. So that could be a confound. They knew the kids practiced that morning. But I would argue from a clinical perspective, I don't think that's what's going on, because staff are not like eager to do a seclusion restraint on a kid. I think that there was less need for it. So yeah, I don't think that was what was going on. I wish the staff were practicing with them, because there actually is evidence from parent studies and from teacher studies that if you train parents, for example, in mindfulness practices, the kids have fewer behavioral problems, even if you don't talk to the parents at all about behavioral intervention strategies for their kids. That changes the dynamic. They're less reactive. Your second question on qualitative data, I've just the last few years learned, I take back everything. I poo-pooed qualitative data my whole life. I'm a convert. I got it. I get it. We are looking at that. The child data is speaking this very positively. So that's the short outcome. They think it's really helpful, and we're not asking for, like, from our school-based studies, the major finding we found from that was that we're not asking them to deploy it with the same kind of specificity that we'd like to, because we were just replicating some of those trials. They were doing it all by themselves. They were noting, I did this at home, and you know what? I didn't get in a fight with my moms that morning. That's huge. And it's even more important in the context of, for me to say that versus when they hear a peer saying that. That changed a lot of the buy-in in that setting. The qualitative research I've been doing recently has been looking, that's that study that came out. We asked experts, clinical scientists, and expert practitioners. Just to show you. We asked 19 clinical scientists and 21 expert nominated mindfulness practitioners. What is a mindfulness-based program? Because it's not defined. And we did a nice qualitative analysis using the Delphi method, which is a really cool methodology for building consensus. And the study we just wrote up is, ta-da, here's the list of the core components. Okay, this is what the expert agreement is today, the constituent elements of this thing we call mindfulness-based programming. This is really important because now we can do component analyses. The study I'm writing up right now, we also asked them, what is the competency needed for a mindfulness-based provider? And so we're working on writing that up right now too.
All right, Josh, thank you so much for your time. We're gonna, for those that are here, we have lunch outside. Josh is gonna be hanging around for a little bit. If you can put up that last slide too,
Yeah.
so for everybody who's online, so your email is there in case they do have questions. But let's thank Josh for his time. Thank you so much.